On to the next speaker, who's going to be Ashvin, who will talk to us on his nightmares.
Good morning, everybody. Thank you, Dr. Amar, for having me on this great panel. I'm going to talk about FACO nightmares and my worst case scenarios. I do have financial interest with LSR, but none of it pertains to the talk today. I'm going to start with a little less intense. I know Dr. Gaurav showed some fantastic cases, and I think they're very important. This is a case of subluxation where, you can see a close to about 180-degree subluxation on the right over here. What I start usually in these cases is with a rhexis, and obviously try to do the rhexis with a little bit caution towards the subluxation, side of subluxation. And once you're done with the rhexis, and in most cases, if you have less than 180 degrees, you can get away with the rhexis. Don't hesitate to make a smaller rhexis. Sometimes in these cases, as Dr. Gaurav showed, obviously you have to be a little careful in where you place your instruments when you go back inside. I do like to place a 4-point fixation in most of these cases. It gives me an enough and wider expanded range. In interest of time, I'm not going to show too much of the FACO part of it, because it goes rather smoothly, especially if you place a capsule tension ring at the end. But most important is the capsular hooks that you place in the beginning. The capsular hooks tries to keep that 4-point fixation. Now I'm using an Ahmed segment, which is basically used with a 6-o-proline suture. The 6-o-proline suture is double flange, so one side you flange on one side using the eyelet, and take a closer look. Make sure that this flange is larger than the one you make inside the eye, because this hole is rather large. So basically test it out before you actually go inside the eye. Release that capsular hook from one side. Make sure that you have a 2 millimeter by 2 millimeter valvular entry, which is what I'm trying to do here. So you use a valvular approach. I try to do this as much as possible. Go into the sulcus space, again, behind the iris into the sulcus space. Come from one side. This is a little tricky. It's trickier than what I'm making it look here. It is tricky. It can be done under viscoelastic, but ideally can be also done under infusion. If you're using infusion, you might need to use a vitrectomy. You need to do a vitrectomy at that side. Now to place the whole segment inside the eye, with obviously the eyelet hanging in the sulcus space. The eyelet is in the sulcus space, and just pull back. It kind of holds the whole bag on that side and pushes the equator as well, which is the main point. I mean, the capsule hook was doing a great job of holding the rim of the anterior capsule, but the equator, the segment really holds the equator of the bag all the way to the side. So much so that even if I'm pressing with my intraocular lens, I'm able to actually withstand that pressure. That being said, if you do find any vitreous at this point in the anterior chamber, make sure that you go and remove that vitreous from there, but I did not find in this scenario. So that means the vitreous did not get disturbed. If there's any disturbance of vitreous, make sure that you go back and remove that. Now I'm flanging that the other side of the flange. It's actually much simpler than actually doing a Gore-Tex suture or any of these sutures that you do, because there's a hammock positioning that you really don't need to deal with at the end of the case. It really looks wonderful at the end because you've not traumatized the eye too much, you've not created too many ports, and you've not created any conjunctival openings as well. So a lot of advantages. The intracameral maneuvers are quite challenging, especially at the time when you're threading the 6-o-proline into the bevel. Coming to show you another case of more than 180 degrees. Here I'm using a different technique. It's called the paper clip hook. If you can see here, again, I'm doing the rhexis, and in interest of time, I will forward out the rhexis and the FACO part of it. But what I'm using here, you can see this is called as the paper clip hook. It's made by Morcher, and this was discovered by Dr. Susan Jacob. The idea here is it hooks onto the anterior capsule, and it works very cohesively with the capsule tension ring. So the idea is when it comes out, if you ever used a paper clip, it really clips onto the papers, and that's exactly what we're doing with the anterior capsule rim. And the idea is to hold that at a 2-point fixation rather than using a capsular hook, which is a 1-point fixation. So a 2-point fixation, you spread the tension on the capsule and you don't allow it to tear. That's the major advantage by using this paper clip hook, and you can do a full-fledged, you can do your cortex removal as is, because you're not going at the equator, you're not trapping any cortex at this point, and it really brings about a very, very nice stable approach to doing these procedures. You obviously club it with a capsule tension ring, which helps in these scenarios. You can see a very central intraocular lens in place, and all you have to do is close that flap with glue, and you've basically tucked that haptic in place. This is your post-op day 1. Some of the dilated pictures as well of post-op day 1, so we wanted to show that. Here is the intraoperative, the OCT or the UB scan over here, and you can see the haptic inside the sclera as well. So some advantages of doing this. I'll take you to one step higher of the phaco nightmares is a drop nuclei with aphakia. Obviously, you will have aphakia if you have a drop nuclei, but the idea here, what I'm going to show you is how do I handle these in a day-to-day basis. I first make my flaps, and this is probably a new age way of handling dropped IOLs or dropped nuclei as well. But I'll show you what I do. I make a scleral wound because this is a larger nuclei. It's a tougher nuclei. If it was not so tough, then I would have probably done a entry with a blade. But I'm going in the pars plana approach, making my incisions, making my sclerotomies under the flaps. These also act as ports for me to enter. And
Ashwin, just 1 minute, Ashwin. Those in the back, please come here. Those who are standing, because
there's some
people
place
from
in front.
outside are not able to enter inside. Can you come here? There are a lot of chairs here in the front. Please continue, Ashwin. Sorry.
No problem. And basically I'm doing an anterior vitrectomy. Once the anterior vitrectomy is done, I'm also making sure my wound is open. Why I'm opening the wound, I'll explain as I go along. Because it's a self-sealing wound, it's a pretty tight wound, it's tight-lipped. Doing a full-fledged core vitrectomy on this side. And once you've done with the core vitrectomy, luckily there was not much post-PVD to be done on this case. Now what I'm doing is using a extrusion cannula. I'm not using anything extravagant. It's just an extrusion cannula that I'm using, and using a bimanual, after you're doing a full vitrectomy, using a bimanual approach or double-handed approach to kind of spear this nuclei with a rod, and that helps to maneuver with a bimanual approach. That's why I said I'm using my ports as pars plana approaches to kind of maneuver this nuclei into the anterior chamber. It's quite challenging, but I think it's the fastest and the cleanest way to kind of come out of this problem in today's age. So the idea here is, after you've done it, I really didn't have too much vitreous, but I just wanted to check, make sure that there is no vitreous in the anterior chamber or anywhere. Once I'm done with this and the glue dial technique, I think you all have seen how to do the glue dial technique. I'm just going to take it very quickly here. So I have one haptic externalized. The leading haptic is externalized. The trailing haptic handshake it from left hand to right hand and externalize both the haptics. Once both are out, again I have a very good self-sealing wound, but I will still do a suture. Just as you know, in all complicated cases, you would rather suture if there's any vitrectomy that has been done in the past. And in interest of time, I'm not going to show the end of this case except for the post-op day 1, and you know how this would look. Ideally looks great at the post-op level. Taking the notch one step higher, and in 4 minutes I have to finish 2 more cases which are interesting.
Just 1 second, Ashwin.
Yes.
On the previous case, could you tell the delegates why are you doing glued IOLs and the pros and cons versus Yamane, both? The advantages and disadvantages of both the techniques.
No, that's a fantastic point. I think a lot of us get confused as to why are we not doing Yamane more. The reason that at least we don't do Yamane is extremely clear for us. There is a lot of tilt, number one. And the second is the maneuvering, intracameral maneuvering of the lenses that we get in India. The lenses which we use are sensor, and I have no financial interest with either of them. Sensor, we use the Bosch & Lomb soft pore, which all used to be there. I think it's stopped now. And we use the Alcon. Alcon's very brittle. If you try and kink it a little bit, it'll break. So you will have to, again, redo the whole procedure. You can't externalize. You cannot cut this lens. It's quite challenging in these already complex cases. The second is the sensor can kink very easily, so you'll have a tilt. So your lens will be in place in the haptics, but the kink of the haptic alone will have a tilt of the IOL, and you'll get an astigmatism. So for us, tightening the position of that intraocular lens, and maneuvering outside the eye is much better in most hands across the world. And you can see the numbers of Yamane globally actually going down a little bit, only because of the fact that the lenses are not manufactured for doing Yamane. The lenses are manufactured for in the bag, and they've been just moved. The one lens that really works in their favor is the Zeiss 603, which is a PVDF haptic. The PVDF haptic is it doesn't break. So those are some of the advantages of doing Yamane if you want to do. Just taking it one level higher, this is a really bad case of trauma, and you can see there's a uveal prolapse, there is a huge iridodialysis, and bleeding or vitreous hemorrhage inside the eye. So first thing is exploration, right? I mean, the first thing I do in these cases is usually explore the wound, make sure that all the wound is can be closed, and I can see a very soft eyeball. So to get a taut eyeball, I'm first placing some infusion anteriorly. You can see my infusion port is placed. It's a trocar AC maintainer. Now once I'm done with that, I'm basically doing a little bit of vitrectomy to make sure there's no vitreous there. All this uvea is 5 days old. It cannot remain there. And I'm excising that uvea, making sure that this wound can be first closed up, examine, explore, make sure that the wound is from lip to lip closed out. Once it is closed out, I'm placing my trocar to use it as a port for me to do vitrectomy. I'm also using oblique positioning of my glued IOL technique. I am going to place a lens in. This is my thought process, plan A. Hopefully it will work. We'll see by the end if it did work. What I'm doing now in this scenario is taking just a simple iris hook to kind of visualize behind. I need to be able to see behind the eye. These are, again, guys, phaco nightmares. These are nightmares, worst case scenarios, so don't think about this in your daily routine life, but these happen. And I do treat these on a daily or a weekly basis at least. What I'm doing here is a PVD induction, so kind of making sure that we can remove this vitreous. Once the vitreous is completely out, I can see the retina is attached. It's pretty decent. It doesn't look so bad. I'm able to visualize the macula, the disc, everything looks pretty good. The red glow is back. I can actually go back and now do, as my plan A was, to do a glued IOL technique. Again, keeping the iris away is an extremely important step. But first make my sclerotomies 180 degrees apart. My incision is made, again, using the iris hook to kind of visualize the leading haptic. Once the leading haptic is externalized from one side, I'm now able to take the trailing haptic inside using a handshake technique again, which is the most favored technique in this to kind of externalize the second haptic. Once both are out, my IOL is now centered. So what am I doing, guys? I'm basically going from bottom up. It's like creating the foundation, clear up the vitreous, make sure that your IOL is in place, then attack the iris. And if I did have a corneal wound as well, then I would attack the corneal wound last. So this is foundation up is the ideal way you want to structure yourself when you're doing this procedure. So the iris technique which I'm using is the hang back technique. I'm using the flap of the glued IOL to basically cover that sutures. And once I'm doing the hand back on one side, I know that that's not enough. I can see a big gaping wound of the optic, which is about 180 degrees. I'm doing a single pass 4-through on one side over here so as to get some closure on that. Remember, I had a huge uveal prolapse on one side, so I have no iris on that side. I'm still going to attempt to try and close that. I know it's a little challenging and all of you will cringe while I'm doing this next step. This is basically London Bridge is what I'm trying to create. I'm going to bridge this gap. At least try. How many of you would not try this? No hands. All of you would try this. Okay, but you should not try this because of what I'm going to create next. Is my own customized iridodialysis there. You can see clearly I have created this iridodialysis by iatrogenically. I have no time, but I will still close this with this case. I had to leave this, unfortunately, and I know all of you will say that, what a bad surgeon he is. I said, I'll leave that flap just like that. But then I thought, I'll close it, I'll anchor it down to one side at least, so that there is, using a hang-back technique, I'm trying to anchor this to the sclera at the side, ensuring that, there is at least, the flap is not in the pupillary zone. Otherwise, that flap would have flopped in the pupillary zone and the patient would not have been able to see clearly. Tried to do as much as we could. The patient did end up with 2 months later. Obviously, this had a vitreous hemorrhage, had a lot of edema at the post-operative immediate period, 15-20 days. So we waited for 2 months. We got a really good result post-operatively. There has been a little bit of glare and halos, which he does get. But apart from that, patient's very happy with the post-operative result. I wanted to thank Dr. Amar, but I do have one more case if you have time. Otherwise, we can. So I have one very interesting case. I thought it's quite interesting to show this. This is another injury, and I'm not going to tell you what is happening inside, but you can see the iris is completely gone. There is no iris in this case. And yeah, so what this is an ACIOL. This is not the PCIOL now. This is an ACIOL with the iris completely crumpled on one side. I'm first removing that ACIOL, and it's a pretty bad mess. The wound is not so great. And you can see here, I'm first going to explore what the hell is happening with this iris. It's just a bundle of joy there. How many of you agree with me on that front? But the idea here is basically to examine this thoroughly, undo what is, you're trying to iron out your trousers but inside a plastic bag. I mean, that's basically what you're trying to do. Trying to iron this out without actually visualizing or feel. You can't feel this, you can't touch this, you can't see even clearly, but I'm trying to undo. First you have to see which side is up and which side is down, right, which is the correct stromal side. So once I'm able to visualize that, I'm first putting some iris hooks so I can at least stabilize the ship. Once I'm able to stabilize some ship over here, I'm trying to first visualize what's below, right? I mean, you have to also go back inside and see the inside, the posterior segment of this case. So once I found my right footing on that front, I'm first placing my glued intraocular lens here. Once I've done my glued intraocular lens, obviously handshake technique, be careful of the iris, keep that iris away from your forceps. Ensuring the IOL is in place, now I can go back and see inside what's happening. And you can see there's a very nice vitreous hemorrhage which is not going to be helping in the vision recovery. So do a PVD induction, ensure that the vitreous is completely out, do a core vitrectomy in these scenarios. Making sure that vitreous is clear is the first job. And again, coming back to that small piece of cortex, or I would say in this case nucleus, I did use an extrusion cannula to kind of lift it and vitrectomy, and use a vitrectomy cutter to kind of aspirate it out. Making sure the macula is clean. Now go back and start trying to see if we can, salvage the situation from a iris perspective. From the iris plane, can I resolve this? And the idea is to use a hangback technique under the flap on that side, on that corner. Using a trocar-assisted iridodialysis repair. So the trocar basically just swivels left and right, and I can use that. One of the biggest problems that we face in iridodialysis repair is what? When we are going in with the double arm needle, it always captures the corneal lamellar tissue. And to avoid it, you just place a trocar on that side, go through the metal lumen. It really clears up the air. In any problems happening in, I'm doing 4 passes on to just cover that iridodialysis. And now I'm doing a single pass 4th row to cover this. Once we are done with this, I can pretty much be rest assured that it looks pretty decent. A lot of you will beg to differ that, probably do one more on this inferior temporal side, and once we are done with this, it looks pretty decent to come out, close the case, and hopefully look for a next day. Post-operative vision was 6/9. I was really happy with the result. This is how the patient looked when it came in, and this is how we wanted to showcase a post-operative case with the ACL damage, trauma. Thank you very much for everybody.